Welcome to the Walk in the Park podcast, the official podcast of the Lead Up Task Force of SAGES, the Society of American Gastrointestinal and Endoscopic Surgeons. In Season 1, we will be taking a look behind the curtain of the C-suite, sitting down with individual CEO, CMO, CFO, CNO, and COOs of a diverse range of physician practices and hospital systems. Please remember to hit the like button and subscribe to stay up to date on the latest episodes. Enjoy the show.
Today, we welcome Hamilton Clark, Senior Vice President of Operations for the Jackson Health System and immediate past Chief Executive Officer of Jackson Memorial Hospital in Miami, Florida. Prior to becoming CEO, he served as both COO and CFO of Jackson Memorial, and prior to joining the Jackson Memorial team, he worked his way up through the ranks of Broward Health, starting out as a financial analyst out of college and working his way up to CFO of Broward Health. Thank you, Hamilton, for joining us.
Thanks for having me. Excited.
So one of the things we always like to start with is just getting to know our guests a little bit. So if you don't mind, tell us a little bit about yourself and some of the key lessons that you learned along this pathway to becoming CEO, and of course now knowing that you're even beyond that. So tell us a little bit about yourself and some key lessons.
I think probably the first thing that I learned is when I graduated, graduated college, I had to figure out what I wanted to do. I definitely wasn't, one of those guys that had a really clear idea of once I graduated college, I wanted to go into this industry, or this was my path, or this was my goal. I knew I didn't want to bust tables anymore and sort of work construction, but where I was going, no idea. So I graduated college and I, of course, was busting tables at night. And I got a job as a financial analyst for a healthcare system. And just doing database maintenance, creating reports for, the hospitals and entities, decision support stuff. And I really, I got a chance a year later to get a promotion to work in a hospital as an analyst. And that's where I really found, really connected with being in a hospital. And while I was in finance, things that I were doing, meeting with the clinical leaders, whether it is the physician leadership, surgeons, or just our nurse managers, I found that I was helping them be able to find ways to run their units, run their departments, run their services, and still be able to take care of patients in a great way. So I really found, okay, I wanted to be in a hospital. And I kind of just ended up in finance. I always joke, I never liked finance, but it got me to be eventually CFO of a 716 bed level 1 trauma. And, I guess another lesson I learned there is you don't know what you don't know, because I kept saying throughout my, growth and elevation, when I get into leadership in the C-suite, I'm going to do this and I'm going to do that. And how could this be? Well, you get in the C-suite and figure out, oh yeah, there's a lot to that. And there's a reason why this is happening and a reason why it's still going that way. So I did learn to appreciate, don't always, look at those in positions of leadership and think they're not doing something to sort of get there. And, I had an opportunity. The CFO of the Broward Health System had, transitioned to the Jackson Health System, which is one of the largest public health systems in the country. He called me up. I was at a publicly assisted safety net hospital at the time. Spent some time in community hospitals too, so had that. And he called me up and said, "Hey, you want to come down to Jackson?" I said, "Didn't you guys just lose $100 million last year?" and so he started the conversation that way. And I kind of they had sort of gotten out. And, they had brought in a president and CEO to resurrect and turn around Jackson Health System, which means so much to the Miami-Dade County community. And if you're someone that connects with mission, not just the bottom line, this is a fantastic place to be. And there's nothing that we kind of don't do. So I don't know. I kind of thought there's no way I can make it any worse, so I might as well roll the dice and sort of head down the Jackson. And yeah, I started my career as a CFO. And it was my first real time transitioning in leadership from an organization I'd grown up into leadership and sort of assumed a leadership role with a new leadership team, not only a new organizational culture, but also a new, very unique and distinct culture in Miami-Dade County. So a huge change for me there. And I got out of finance. I was joking with Marky. I said, what do you want to do? I said, I want to get out of finance. He's like, you do know you're applying for a CFO job, right? I said, well, yeah, but I want to
So
get into operations.
So at that point, you were CFO too. So you're kind of, it was a CFO to CFO move. Is that what it
Yeah,
was for a
CFO
moment?
to
Okay.
CFO of Jackson. Just Jackson's a 1,500 bed hospital, larger facility, and kind of in the same wheelhouse of what I have been doing, just kind of on steroids. And I had the opportunity in a couple of years to get in operations, to be the chief operating officer, which I think I really enjoyed. I mean, that's where I got to really work with all of the frontline staff. And I was a frontline leader, even up to a couple months ago when I transitioned to the corporate office. As I shadowed nurses for 12-hour shifts, shadowed OR nurses, floor nurses, pediatric nurses. I really found that you can only really know what you're advocating for and what's really needed if you really got in there and learn what the struggles were on a daily basis. And that gave me a platform to speak from because I came from the finance world and not clinical. So from there, they need a CEO of the Women's and Children's Hospital. And I gave that a shot. And, as COO, I really realized what my end goal was, and that was to be a CEO of my own hospital where I really could implement my vision, build my team, my culture, and sort of see if that worked. And I had an opportunity at Women's and Children's. Amazing opportunity there, guys. Like I don't probably the most rewarding experience of my career because not only do you work with the most passionate set of healthcare workers on the planet, but I also stepped in there during COVID. I was CEO for about a year, so I got to usher in the pediatric world and also the women's and the OB and L&D world, which was a really big piece of that. And we're very research based, so we're doing all kinds of COVID research on both of those with kids and. Opportunity opened up to move over to Jackson Memorial, go back there to the big house, and a few years there. And, after 27 years, basically working in hospitals, they asked me to come to corporate and be over sort of all the 7 hospitals, the institutes, entities that kind of, bring together efficiencies across the health system, break down silos, drive standardizations and protocols and cost structures and things like that. So, yeah, it's been a couple of months for me. I sort of debate on pulling the fire alarm every day just to feel alive again. But in
Nice.
the corporate office, I get along great with these guys, and I think it's a chapter that I never really thought that I would go into. But I'm going to give it a shot, and I'm going to see what good that I can do for not only the community here, but for also all of our incredible healthcare workers that are doing this every day. So. That's my summary story. I'm born and raised in Fort Lauderdale. I'm a water guy, surfer, spearfisher. I want to spend all my time outside. So strange that I work for 70, 80 hours a week. It doesn't really make much sense. But I guess I don't appreciate quality of life as much as I should.
Yeah, that doesn't match, but at least you're in the right location for that. You stayed close to home, and hopefully you can use the remaining hours to get out because you're certainly in a good environment for that.
Yes, sir.
Well, and it's a great story, right? And we appreciate you taking the time to kind of take us through all that. So now that as you've evolved, as you said, going through the different roles, how would you define your leadership style? Like what strengths do you think you have brought or developed over time that has given you the ability to be so successful and to, as you said, kind of move up in the hospital world?
I certainly would probably point to relationship building and collaboration. Um, Sort of the further up that I got, it became incredibly apparent that if I didn't take the time to understand, what the other side of the table was experiencing, what the pressures they were going through were, and I realized I wasn't going to be very successful if I didn't sort of build that appreciation, no matter where I was. I would also say, like I mentioned, being a frontline leader, I felt that that was a way that I was able to, inspire and engage, large groups of people in change. And change is a harsh thing that you can hope to do. I mean, when you really think about it, you're either working with physicians or surgeons that have been practicing this way for 2, 3 decades, or you're working with, thousands of nurses that have been practicing this way, taking care of patients this way, and really, inspiring them in a way that, convincing them this is why you want to change, and I'm changing with you. It's definitely not the, not the lead through fear, but lead through inspiring and going above and beyond to sort of explain the why it's important of what we do. And one of the also ways that I always sort of would revert to is would stop in meetings and even say, "Hey guys, let's start over, and let's start from the patient and family's viewpoint and experience. Like, let's really start from there and really have that patient and family centered sort of care model. Because, yeah, I mean, we're all human, we're all selfish at a certain point. And, hey, you want me to do this now? But I have clinics on that day, or man, you want me is better for the patient to be seen here instead of walk, half a mile to the hospital, but it's right next to my office. It's just, and there's a million examples of this, but I'd say, those are the things. It certainly wasn't. I'm rarely ever the smartest person in the room, and when I am, I'm with my 10-year-old daughter.
So sounds like a future budding administrator slash. What does she want to do? Is she going into healthcare, or you just steer her away from that?
Yeah, it's tough, but she's incredible at math. Strange because like I said, I didn't like finance, but I was good at math. But she's into the arts, right now. She's really into the arts and into martial arts. So I'm just facilitating that. And who knows? I mean, because I can't. I certainly am not one to give advice because I didn't know what I want to do when I was 22, let alone
yeah, let alone
10. So
that's awesome. Yeah, my two are also into arts, the girls, but the boy, who knows, he's also getting close to 10. So
yeah,
but yeah, it's fun to watch them differentiate.
Cool age.
So I know you touched on kind of your being on the ground, and I think that's a fantastic way to lead. One of the groups that we're really going to focus on as the SAGES members are the the surgeons, but also the physicians. So how would you describe your relationship with the physicians who work for you? The surgeons. I know that we specifically talked about some of the challenges that you might have working with one Dr. Ross Goldberg. So feel free to throw that in there. But yeah, what's your relationship like with the physicians and the surgeon staff?
Very positive. I mean, the biggest thing is to always be available, just like, physicians to their peers and referral patterns. The number one thing that they really want is you call and that physician or surgeon is answering. So have a very good relationship with them. Some uniqueness, since I've been, in the community world, a little different with the community model versus the academic model. I mean, Jackson Memorial Hospital is the epitome of an academic model where 95% of the physicians that staff that hospital are University of Miami faculty. There's 1,100 residents and fellows. So there are different ways that you can incentivize and work with those different groups, because they have different needs. Just understanding what those needs are that'll make you be able to engage them to facilitate change.
Great. And then so here's a follow-up for that, because you're talking about the relationship building. So we are unique. We obviously interact. Personally, I know I interact with you in my role, but what advice would you give for the average run-of-the-mill physician surgeon who's coming doing their job, taking care of patients, who's not in a leadership role? How would you encourage them to engage their C-suite, to reach out to their CEO, CFO, COO? Like, from your perspective, what types of problems or ideas would you want kind of your everyday physician to bring to you, which you wish they did more of here at Jackson too? So what advice would you give to kind of our members who don't know where to start, or they just see the C-suite as this kind of entity that they're afraid to approach because something may happen to them? But how would you help them overcome that barrier?
Well, I think one thing is that whole. I think C-suites as a whole are kind of changing. I mean, all of us now on this podcast are from a bit of a younger generation, and I just think that everyone may say they have an open door policy, but I think that C-suites that really want to get that feedback, and I think that there's nothing better than when a physician or a surgeon, I call them or run of the mill, but I wouldn't call any surgeon run of the mill, because that is a lot of training and a lot of residency and a lot of work it took to kind of get there. But I mean, I say that a couple of my suggestions would be is one. I mean, yes, you first have to go into the door, and of course, it was my mom that taught me always get in good with the assistants. That's never a bad thing to do, but I mean, to just go in there, meet people. If ideally, we always had it to where we have a physician dining room, and it was a requirement that we eat 2 or 3 times a week in there, make ourselves available, meet the physicians. I'd say that in from that actual engagement, it's the way that you're providing the feedback. I've had surgeons that, I'm very honest with them and say, they're not providing feedback in a productive manner. And what that does is you lose your audience when it sounds like you're just constantly, it's not like yelling and screaming, but just really always complaining, yelling, saying this, but not providing any solutions. If your approach is very productive, you'll really get an audience very quickly. Whereas on the other end, if you earn a reputation of being sort of that physician that is, it's just so and so again, they've always been this way, it's tough to break through that. But I've also been able, those physicians, surgeons that have been here for 30, 40 years. I know, Dr. Goldberg, you're lovingly dealing with a lot of them now, but I've been able to engage them and say, hey, you have incredibly good feedback, but the manner in which you're providing it is unproductive and the audience is turning you off. Like everything that some of these, what has been deemed as a difficult surgeon, has a lot of good advice and a lot of good things that happen. And a lot of these physicians have probably been saying this stuff for a couple decades and nothing's been done. So the other big thing is, as an administrator, you have to show that you've listened and you're doing something about it and you're following up. And that then gets engagement on the other side. And then the physician group will feel more comfortable coming to you because they see that you are listening and you are doing something about it.
Yeah, I mean, I think that's such a huge point. I think just working for several different leaders, I think that's probably one of the most frustrating things from what you said, frontline physician, surgeon, is maybe identifying a problem. That you shouldn't go to your C-suite with just problems. You identify a problem, you propose a solution. You may have even seen that solution come to fruition. and then there's like crickets, right? Like you don't hear follow-up, you don't hear feedback. And I think over time that certainly can really lower the morale of an entire group of people, and then you just don't hear from them anymore. So I think that feedback loop, if it's not closed, you're going to struggle. I think with that gap is going to continue to widen and just become very difficult to bridge.
Yeah, great point. I mean, it happens all too often, and you can't do that. You have to have that follow-up mechanism. I mean, there's I don't know, there's little that's more important than that, and it's not just with our physician groups or surgeons or the frontline staff. If you're going to them and having an employee engagement survey, and they take the time to tell you what's going wrong and do nothing about it, yeah, good luck going back and trying to see what is going on.
Yeah, so I'm also at a public health system, and you've already alluded to some of the unique challenges of public health systems, and you're certainly at one of the largest in the country. If you were to maybe rank some of the most significant challenges, maybe one or two, what would those be? And then maybe speak a little bit about some of the relationships you've had with private C-suite community members that maybe have had some some strategies to address those.
So I want to make sure that the first was sort of the public health academic model. What are some of the challenges there? And then on the other
Maybe
side,
the top one or two. I mean, we can rattle
yeah.
off resource limitations, staffing, kind of the standard ones, but maybe some of the ones that have been particularly vexing for you in your time as a CEO, and maybe then linking that in with, I'm sure you have private C-suite counterparts that maybe you're envious of some of the resources they have, or just what are some strategies that you've learned through kind of, even though you haven't been with those private groups, maybe if they've had some things that you've tried, or just kind of learn through that.
Yeah, I have worked in my prior hospital. I know it was a public hospital, but it was staffed by a private group, and
Okay.
we have three community private hospitals here at Jackson, so I can
Oh, great. Okay,
speak to
perfect.
both, and I
I
only
didn't want to throw you under there. I didn't know that there were some private ones there too. So
yeah,
yeah, speak to that then. Perfect.
I only get one or two. Okay,
Yeah, one
well,
or two. One or two. We don't have enough time.
yeah. So I would say from the public hospital standpoint, I would say the governance structure tied into the county, all the procurement code, surgeons, physicians, like I need a new tower. I need a new orb. I need new this, that. Okay. Well, we're working on it. It's going through procurement. It's going through the code. It's going through that. So, speed to get those things done is very challenging. But once again, that's why keeping that group informed is very important. I would also say that from a public standpoint, there's this moniker. We have, we're a 7 hospital system. And we function really more we have a private hospital feel, but have that moniker that, we have to change after decades of what I'll call probably, not having the vision to sort of change, the idea of what Jackson Health is, and, that public idea, trying to change that. And because we are academic, I will say it is having 1,100 residents that are rotating out every single year, getting whatever you want to call it, 250 new residents every year. That group manages your patient population for the most part. How do you engage them? How do you incentivize them? And then with the university model, that academic model, different from the private practice. And once again, that everything is about incentivizing, right? Like they're basically salaried. They might have an RVU bonus or kicker somewhere in there, but if they're not how do you get them to see the benefit of, seeing more patients, getting more RVUs, or how do you incentivize them? So we have medical directors, and if they're faculty members, they're not getting that check in their pocket. It's just giving them some more protected time. So on the community side, let's talk about the incentives as well. Somewhat easier. You can incentivize, physicians to help you with your quality metrics, efficiency metrics, and have them be medical directors, et cetera. You can cut them an individual check, and Dr. Ross Goldberg is actually seeing, here's your work from the month of May for helping us out. And so that's a bit of a struggle there. And in the community side, there's a lot more competition, to where they're saying, "Hey, this hospital's offered me this call pay," and those. So I would say the difficulty of balancing your margin, with sort of this, what I'll call an arms race, for sort of that sort of volume.
And yeah, I think I've seen that recently. It's an interesting dichotomy. Yeah, it's one side on the academic, how do you get them to do more? And then almost you don't want to price yourself out, but if you don't on the private side attract people, you've got a nice building that doesn't do much. So I definitely can understand the struggles there. To change direction a little bit, something, and you've been actually very kind of open about this. So there's stories out there about, when you had your stroke a few years ago as a healthy 46-year-old and ended up becoming a patient at Jackson Memorial and going through that process. What do you think from that experience as a patient at kind of your own hospital, but just as a patient, for a prolonged period of time, affected your leadership style, your kind of view, how you approach things as CEO? How do you think that kind of morphed and kind of evolved your approach to everything?
Yeah, I was probably the worst patient the hospital ever wanted. He's kind of, I mean, I'm sitting here as the, leader in that space, and I'm going, "Hey, why haven't you discharged me yet?" "No, I'm not going to wait here for a TE. That's an outpatient procedure." So that's probably a little difficult in that space, but certainly, I gained enormous appreciation for the work that's being done, an enormous appreciation for academic medicine, because, just being honest, from an administrator standpoint, the academic model, in some ways, being efficiency, margin, things like that, is a difficult model to have, right? But when you're in it, and when you see the academic model work, and that multidisciplinary sort of approach, I certainly gain more of a value there. And from a leadership standpoint, quite honestly, it was during a time where I certainly had to establish myself as a CEO. And, it gave me sort of a platform and an opportunity to say, "Hey, this guy went through this. He was back at work in less than a week." And, it gave me some sort of credibility. Like, it gave me a way to sort of show that, hey, we can persevere. Nothing's impossible. Like, I couldn't use my right hand. I couldn't feed myself, 10 days ago, but here. And then, so show that progression, show that perseverance was a way I thought was a platform to inspire and get people engaged.
That's fantastic. I think that fits very well with this next kind of idea, which is the podcast itself was born out of a initiative called the Lead Up Initiative, and it became a task force within SAGES, where really the goal was to develop resources and try to re-engage our members to lead up, to lead within the environment they were in. And even though, maybe they don't have official titles, but want to be engaged in leading and changing and really getting better, really. And I think you addressed that about getting better for our patients, making sure that we're offering the best care for everybody. So, what advice, you've clearly seen many examples and have alluded to a couple examples of how how to behave and how to ask for things and how to be effective. But what's some advice that you have for, again, a physician maybe doesn't have a title, is not a chair, is maybe not a division director? How can they start having a positive impact in their hospital and healthcare system? Maybe not just within their own little sphere of their nurse and their own patients, but if they want to have a bigger impact, what's some advice that you have for them?
Certainly participate in M&Ms or committees. There's always ways to get involved by. You don't have to walk into the C-suite. I mean, hopefully the OR leadership team is there. If we're talking, I'll go specifically to surgeons. To work with them, how can I help? And that's always a way too. I'd say that this, and I use this more, in sort of my talks and my meetings with surgeons, and they're not leaders, or they can be leaders, but they want the latest and greatest piece of equipment. They want the latest and greatest whatever, O-arm or whatever it might be for neuro or something like that. I said, okay. I'm very big at showing the numbers, because this is where we stand, and this is why it's difficult for us. Is there a way that you could help me out? I know that you've been using, I don't know, I'll just call it a Stryker for your implants for all these years. We're trying to get them to the table, or we're trying to standardize, or know you've worked with this rep for a long time. I know that relationship is very important to you. Is there a way that you can help us get a better rate here, because we're not getting paid any more money for doing anything, and the costs are just going up, whether it's salaries, supplies, et cetera. This is a real problem for us. And if the margin keeps going down, how are we supposed to keep providing this level of care, this level of technology? So then coming to that and just being aware in the background that, even if it's helping with first case starts or block utilization or whatever it is, I think it's that, like, how can I help you? Help me. I mean, and a good administrator is going to end every meeting with, how can I support you? Anything that I can do.
And I think that's a great point. And as a reminder to everyone, is you also need to start the conversation. You have to go approach your leaders to start that engagement. Don't just expect people are going to come up to you. It's okay to reach out. And you touched on a couple things, and Kevin actually mentioned it earlier as well. Resources. And I know we could talk hours about that, and you and I have personally had conversations in the past about it. So it's no surprise that resource utilization is constrained for the healthcare system in this country in general. Safety net hospital, big health system, governmental body, you have unique views and experiences of having to deal with limited resources. So how do you prioritize, given that we have X amount to be able to do, how would you prioritize resource acquisition, to keep things working effectively, like you just said? We know everyone asks for the newest and shiniest thing. That can't always happen. So how do you triage and prioritize that?
Yeah, everything is from an administrator standpoint, whether it's private or not, you're prioritizing priorities, right? That's kind of it's kind of what we have to get a skill at. But say, and most of this is the OR, because that's your high cost. That's where your supplies, resources, equipment is, things like that. But it could be something, like they want the latest and greatest CT scanner or a 3T MRI, because they want to, have it. There are those sort of things. But, from an OR perspective, we certainly, first off, there is quality of care and safety, which is not, if we provide these services, we have to be able to provide that equipment, resources, staff, instrumentation to be able to do this. If a certain service line or a physician surgeon's like, hey, this is This is coming out. This is what it's going to bring. Okay. Well, we're going to prioritize things that are going to bring incremental revenue. Is it a new way of doing something that's going to, reduce blood loss or reduce the length of stay, or is going to engage a new, patient population to differentiate us from other facilities? Robotic surgery is one that sort of comes to mind, but there's others in there that we have tried, but prioritizing that, and also, so I mean, things that have a margin. There is replacement equipment. I mean, after 7 years, 8 years, you're going to have to look at replacing CT scanners. Like we're not having a discussion surrounding that. I think it's more of sort of that incremental piece, of sort of how do we offset? Like you want this, you want new trays, you want new these, how can we talk about, what's going to help us have a return on this investment in some way? But like I said, I want to highlight, nothing that affects patient care is going to be sacrificed. Like that sort of is priority.
One of the main groups that we also tend to exclude from high-level discussions are healthcare trainees. And you mentioned that there's a lot of trainees there, and we also have a fair amount of trainees in our system. SAGES has a pretty significant focus on making sure that the next generation is better equipped than the previous generation was, not only in the clinical space, but this administratively too. You didn't get to meet our other co-host, Julia, because she's duly operating and wasn't able to make it. But she represents the residents and the fellows who are coming up. How would you counsel SAGES trainees to incorporate relationship building at the C-suite level within their training? I mean, they're already managing a lot clinically and administratively, but I think it's important, and I want to make sure that we give you a chance to kind of mention some strategies that you would recommend they do.
Yeah, well, I mean, I'll start by saying, it's on those C-suites too, right? I mean, it is
Two-way street.
Yeah, I think that organizations, and ours is not exempt from this, but don't do the best job at engaging, those learners, that sort of, all our residents and fellows to the level that we should. There's pockets, I mean, we have a couple of programs where they have very strong program directors, very strong chairs of those departments that are incredibly engaged and aligned with administration, and they do have that forum in that. Now, if there is a group of sort of residents and fellows or learners that want to get more involved in those, because these residency programs are doing projects that are driven from their sort of GME requirements and things like that, but you really want to get involved. I would recommend, starting with the GME leadership, or if it's specific to one service, if it's something in the OR they recognize they want to change, or if they're on a different rotation that's taking care of floor patients, they recognize that, go to that nurse manager, that leader, and bring it up there. Or, like I said, I know that I can't speak for every administration, but I can't count the number of frontline staff, frontline leaders, physician leaders, residents that come in and out of our administrative suite. Like, we really wanted to we gave everyone access, to try to create that culture. But I think that as a whole, us administrators need to do a better job at engaging and also aligning, with, I don't think all of our residents know and understand what are the challenges, what are the goals, what's the vision of the hospital which they work at, and how do they fit into that? How can they help?
I mean, there's such a diversity in how people want to receive information, how they want to be communicated to. And so, especially with the next generation, how long of attention you're going to have from them. Are they going to read a half a page email versus, watch a video? And so I'm sure those are all part and parcel of the challenges that you face to try to communicate initiatives and the vision and the mission and everything. So I'm sure you probably got a team of people that says, well, now we have to do it in a 30-second snippet, right? And I think it's such a challenge these days.
Yeah, incredible point. I mean, we actually have leadership training and on how do you communicate with, how do you engage? Because we have, Gen X, Gen Z, we even have some boomers hanging around in there, still working. And, you kind of each group, reacts a certain way to a certain amount of communication or wants a certain amount. Of feedback and appreciation, and it's just different levels along the way.
I look forward to maybe the incoming Jackson TikTok videos I guess we'll be seeing for you guys interacting with us. I guess maybe that's in the future. I'm not volunteering for that, by the way. Just I'm putting that on the record now. Um, we really appreciate, everything you've told us so far, and we know how precious your time is, and we really do appreciate you taking this time to talk to us. And obviously, we know there are a lot of people who are vying to probably speak to you right now as we're still talking. But before we let you go, we've asked a lot of questions, but from your perspective, is there anything that we didn't ask you or think that would be helpful to discuss to help bridge that gap to, what did we miss an area that we didn't discuss yet for our listeners so they know how to engage with their C-suites? Is there any point you'd like to bring that we haven't addressed just yet?
Um, yeah, I definitely have a couple. I will start by saying too, it's never been more important than now for both parties to be at the table discussing and trying to understand what the pressures are of the other. Because you understand what that is, come to happy median, sort of both are happy. And I will say too that a lot of times, physician to physician communication, administration gets brought in the middle of a lot of those, and I'm not going to get into the psychological reasons why or whatever that is. I probably should have gotten a psychology degree before an MBA in my role, but I do think that a lot of times. Physicians will not speak to their peers. I mean, Dr. Goldberg, I'll use another, OR example, but, surgeons and anesthesiologists and, kind of where they're specific. We have teams for cardiovascular thoracic and transplant and sort of, peds and, specific groups that serve those. And a lot of times those physicians, for whatever reason, either don't feel comfortable having that conversation with their peer. And really administrators, we sit here and say, oh, okay, you have a problem with them. Either I'm not clinical or all we're going to do is facilitate a conversation. So I think, that's just one that I would say that, it's obviously not, blanketed across, everyone, but I would say that that's something that I have seen, with some consistency that I think that, physicians going to their peers, sitting down saying, hey, can we talk this out? This is what I'm seeing, as sort of first start. I mean, Dr. Goldberg, as our medical director and chief of perioperative services, often is put in the middle of that, probably daily, hourly. I don't know. I'll let him answer that question, but I think that would be go a long way and say, yes, I did sit down with Dr. So and so. We had a conversation. We were not able to come to an accord because of so and so. We need to get brought in at that point. And then I'll say too. If physicians do want to get involved and be a part of change and have a leadership role, it's to approach it that way and say, I have some ideas, I think I can help with this and I can engage people. And then administrators are very, very open. They're saying, okay, I will provide you, 10%, 20% time or whatever the hours you work out if you're in a private community hospital, an average hourly rate. We are very open to providing you with this stipend to help us accomplish these goals. And that's the key part of it, is that what we're asking you to do needs to be tied to a metric that's going to show that we're driving change. It's not all about money. It certainly can be quality, et cetera. But, that's a way that if you truly want to get involved in that and appreciate why, there's also, websites and there's literature out there to learning what are the hospital, like Leapfrog, our Leapfrog safety grades or CMS star rating, all the stuff that hospitals are focusing on, and everything that goes into that, that's going to drive what their strategy is for the upcoming year.
And I think that's a great point. That last part of what to speak and kind of your way of communicating. And I laugh at the first comment you made. Yeah, they don't want to talk to each other. They have no problem calling you though to tell you about it, but sitting across from their colleague seems to be a challenge. Kevin, and if you want to jump in too.
Yeah, I would say that's a universal problem, and I think the generational aspect also likely contributes to that. I think that the younger, and we're all relatively young, I would say, but even younger, it's like face-to-face communication is very challenging for people these days. And I'm, even in my own role, I'm a clerkship director for medical students, and I get rave reviews in person from them, and then you get their end of rotation evaluations, and that's when they let loose, right? And so it's usually the written, anonymous feedback that's like, this doesn't match what was going on verbally for this block, and so I think there's a lot of opportunity for us as human beings to to communicate with each other face to face, and be courageous with our challenges, be courageous in how we address one another and not be scared to, have some delicate conversations, because I think administrators do play an important role, but there's also a role for us to just be professional amongst each other. And I'm saying that to myself as much as I'm saying it to everybody else.
What's a courtesy too, right? I mean, sure, this never happens in our OR, but if there's an emergency case that might bump a scheduled case, the call goes to, the OR leadership, hey, I need this OR. And, the ideal world would be there's a relationship where that surgeon calls the surgeon that has that block and has booked, say, hey, FYI, have an emergency cannulation or whatever it might be. And okay, yes, I understand. And then, I think that that goes a long way from a courtesy standpoint. And I know that is kind of universal in no way, and I know that surgeons are incredibly particular and deservedly so. I mean, what they're doing has to be that way, and they can be very demanding, and that's okay too. But how do we come together and figure out what's best in a productive way, what's best for the patient, et cetera. And yeah, I would say that that's probably the only thing that I would say may have been missed.
That's great.
Fantastic. Really, we want to thank you. This has been incredible. This was everything we hoped for and more. I really think our listeners are going to get a lot of information out of this. Again, it's pulling back the curtain. That's why we're calling it Walk in the Park. The idea is to kind of understand from where you come from, because obviously, as you've said, we work as a team, we work together. I think people are going to really enjoy this. We thank you again. I hope you have a great day, and I will try not to bother you too much throughout the day at work, but I don't make any promises, as we know. And I do take advantage of that open door policy. The admins are confused when I don't show up randomly into the C-suite now. So, but Hamilton, thank you so much. This was really great. We really appreciate it.
I heard he just likes the cappuccinos that you have there. That's what I heard.
Yeah, well, that's a good one. Thanks for at least trying not to bother me too much during the day. I appreciate you at least trying.
Awesome. Thanks so much.
Thank you.
All right, guys, take care.
Take care.
Thanks, Hamilton.
And that concludes today's Walk in the Park episode. We hope that today's discussion provides you with both resources and motivation as you lead up in your practices and organizations. Follow us on X, Instagram, or your favorite social media platform at sages_updates. Tune in again next time and reach out with any thoughts on how to improve the podcast. We are open to suggestions. See you next time.
Ross, so how did the Eskimos or how did the Eskimo build his house?
I don't know, Kevin. Why don't you tell me?
He glues it together.
Yeah, this one I'm going to apologize to our Sages members for.